we can, and you probably have something you have to check okay to do that. Anyway, and so welcome Amanda, and with her is Sean Burke with the O'Connell Consulting Firm, and he consults with Minnesota Elder Justice Care Center, excuse me, Elder Justice Center. And so they are welcoming questions. Put them in the chat, please, because they will monitor the chat and answer questions as they come up, or, you know, if they know they'll be addressing that a little later, they may just wait and address it then. But so we'd just be happy to have you put questions in the chat. And Amanda, I think you're going to begin, correct?
Sure, and happy to start. I will share screen and hopefully it worked just as good as it did when we tested it, correct?
Exactly.
All right. Okay, so well, thank you for having Sean and I here today. I really appreciate it. Like Colleen said, I'm the executive director at the Minnesota Elder Justice Center, and I just want to take just a minute and talk to you a little bit about our organization. We are a nonprofit organization. We're an advocacy organization, and advocacy for us means both direct support victim services and also some policy advocacy. So really both the micro, how do we help the person, direct services, and how do we address systems change and issues. We were founded in 2014. Mimi Siegel, who's a part of your league, is on our board and has been since the beginning with me. So Mimi has done a great deal of work with us to get the center where we are today. And so we do provide free direct services, support and advocacy. So a helpline, and we have advocates that you can call and ask questions to get support from, really around the issue of elder abuse, neglect, financial exploitation, and maltreatment. So really our core issues when we say the Minnesota Elder Justice Center. So whereas you think about AARP has broader aging issues, we're really looking at maltreatment prevention, abuse prevention, financial exploitation prevention. So we do have that direct services to victims. We also have some legal advocacy and legal representation. So some free legal representation for individuals when it's related to a safety issue or a housing issue. We do professional and public education like we're doing today. And then we do policy and systems change work. And frankly, the assisted living law is an example of the policy and systems change work that we do. And you can find more about us on our website. And if you don't write it down now, you'll see it again on the last slide. So tonight, what we're really going to be focusing on is the assisted living licensure law. How we got to the point of having this new law, what the law is, what's different from before, what type of resident protections, consumer protections should you now expect and you can find in assisted living facilities because of the law, and what's next. Nothing's ever just sort of passed and created and done. And so especially something this big. And so really talk a little bit more about what's on the horizon and what you can expect. So how we got here, and I won't spend a ton of time on this, but it's really important to think about how did we get to the point of creating this, an entirely new system on how we regulate and license assisted living. So you may remember, you might not remember the dates, but in 2017, the Star Tribune did a 5-part series on abuse in long-term care. And that was really the public's sort of first exposure to some of the maltreatment complaints and some issues that were in long-term care. I will say that for those of us working in the industry and at the Minnesota Department of Health themselves, there has been, and they knew of, a historical backlog of cases in the Office of Health Facility Complaints. And we're going to talk about the Office of Health Facility Complaints a little bit, but that is the office that really oversees and regulates the and responds to claims of maltreatment or abuse in long-term care facilities, nursing homes, assisted livings, anything that's licensed or regulated by the Minnesota Department of Health. Any complaints of maltreatment are responded to by the Office of Health Facility Complaints. And in the fall of 2017, what came to light through this Chris Sears Star Tribune series was really the immense backlog of complaints that were not being investigated, not even being looked at for a myriad of issues: staffing, funding, leadership. There were all kinds of, all kinds of issues that led to that. But then once the public became aware and could hear about these cases, that was frankly a great impetus for pushing the legislature and the political powers, the political players at the time, to do something about it. Okay, what do we need to do to fix this? And so at the time, Governor Dayton created, soon after that report came out, I think the report came out in November of 2017, the Star Tribune series came out. And by the early December, Governor Dayton had convened a consumer work group calling for, frankly, changes, and created this work group and said, tell me what's going on and tell me fixes that we need to do. And it was just consumers in this work group. And so by that, we mean it was staff from the Minnesota Elder Justice Center. I sat on that along with one of our board members, Iris Freeman. We had AARP, we had Elder Voice Family Advocates, we had the Alzheimer's Association, and we had Legal Aid, the Disability Law Center. And so it was really those 5 groups that we had 6 to 8 weeks to bring all of our ideas to the table and create what we called a report to address abuse and maltreatment in long-term care facilities. We released that to the governor, I think it was January of 2018. And right at that same time, the prior MDH commissioner resigned, in part, most because of this. And after January 2018 is also when the legislative session starts. So that's this report is launched, is released. And in that report, we called for creating an assisted living licensure law. Minnesota was one of the few states that up to this point didn't actually have a licensing process for assisted living facilities. There were other regulations, and Sean's going to talk more about what it was and what it is, but there was no licensing process for assisted living facilities like how we have it now and how we think of that. So 2018 ended in a stalemate. I don't know if any of you recall, that was the year where everything went to the omnibus bill, including many of our proposals, and Governor Dayton vetoed it for other reasons at the end of the session. And so we all ended with nothing. So we came back together in 2019 and worked not just with consumers, but also with Minnesota Department of Health staff, provider organizations, so long-term care facility representative groups, so leading age care providers. So we sort of had everybody at the table. MDH convened many working groups, and we traded off chairing them, and we worked together, and not everybody was happy with everything because it was a collaborative process. But we worked to have the Elder Care and Vulnerable Adult Protection Act finally signed into law in May of 2019. So Governor Walz was the one that actually signed it into law after it passed. And we were thrilled to have him do that at our World Elder Abuse Awareness Day conference. So within that Elder Care and Vulnerable Adult Protection Act were many things. One of the biggest things was the creation of an assisted living licensure program and system. And within that, we knew it would take 2 years. So it was always set to start August 2021. So this is why we're talking about it more now than we were in 2019, because we had 2 years to sort of develop some of the rules within the assisted licensing structure. So some of the key parts of the Elder Care and Vulnerable Adult Protection Act was the new assisted living regulations that replaced, and Sean will talk more about this, the old sort of what we called housing with services model. Many more rights and protections for consumers in this law. So rights around discharge or termination from facilities, retaliation protections, the use of consumers to consumer use of cameras in facilities, which had been an issue that Minnesota Elder Justice Center had been working on with others. Gosh, I think that started in 2017, and it was never actually in law. So this also now expressly states that consumers have the ability to place a camera in a facility. And it was always, like I said, designed to have assisted living licensure begin in August 2021, which it did despite COVID. It was not without that certainly, like everything else, caused hiccups in the process, but we felt really strongly that it needed to proceed and still begin in August of 2021. And so the consumer advocates, as we call ourselves, really pushed for that. So I really want to get into the meat of what is in this new assisted living licensure law. This is how we got to this point now. And I'm going to turn this portion over to Sean, and he is going to talk a little bit about what's in it. What do you need to know? What should you be thinking about? What are the protections that you now have that maybe you didn't have before?
Great, thanks, Amanda. So great to be here with you tonight. Just a couple of things as Amanda was talking, the memories of those years came flooding back. Both Amanda and I were really on the ground doing a lot of this work. Amanda was in that original work group that she mentioned, and then I was hired essentially right at the beginning of 2018, right when the work group was done, and we tried to pass laws around these issues. And so I was at the Capitol for those 2 years. I remember the omnibus bill being vetoed. I also think it's important, just as a footnote of history, it was the commissioner of health resigned, and the current commissioner, Jan Malcolm, was hired really to fix this issue in a lot of ways. This was front and center, both politically and just as a policy matter. And so it's quite the footnote of history that she was brought in to fix this issue, which she was a key part of why all the stakeholders got together in 2019 and really, were forced in some ways to compromise on certain things and came up with a comprehensive bill. Of course, no one would have imagined later that year, or just less than a year later, that she's really going to be known in Minnesota for everything she's done with COVID. It's also, I think, important to note those 2 years between when the bill passed and when the law just came online just a couple months ago in August, a few months ago now. No one contemplated COVID for that either. We thought 2 years for normal times for a department to get up to speed and running seemed about right. And of course, they had to deal with COVID in the middle of all this. So I do think it's important to recognize just there are hundreds of people who have been responsible for not just kind of all of the work before this, but now the rolling out of this law. And I think this slide really tells kind of why, because of how many people are touched by our elder care regulations in our state. 65, at least in these days, is a little bit of an arbitrary number. Of course, it's what we use for a lot of what we call aging at the Elder Justice Center, though. Older adults is not a fixed number. But just to kind of help ground us in really what we're talking about, how many people we're talking about. We're close to 1 million Minnesotans who are over the age of 65. But when we're talking about those who live in long-term care facilities, it's quite a bit smaller chunk, although important chunk, those with a lot of acute care needs. We have about 350 nursing homes in Minnesota. That's about 25,000, 26,000 beds. Those numbers are not filled at any one time, but that's generally what we're talking about. We have way more assisted living. And this is really what happened over the last 3 decades in the United States. We moved from a model where most care is done informally by unpaid caregivers, spouses, family members, friends, neighbors, adult children. But in the paid caregiver world, we've really moved over the last 3 or 4 decades from the nursing home, real institutional model to other more home and community-based models, and assisted living is kind of in the middle. It has some elements of an institution. It also has some elements of being home. You'll walk into an assisted living and One might look like more like a nursing home. One might look like more like a single family home. And so how you regulate these settings is difficult. We have about 2,000 of them. And it's really notable that most of them, 2/3 are under 30 people. And of that, most of those are under 10. So in fact, most of these settings are smaller settings, although there are plenty of larger facilities as well. And when we talk about full capacity, we're more than double the amount of assisted living beds than we have nursing home beds. The other key difference, and we can talk about this a little bit, especially if there's questions around this, the assisted living world is is mainly made up of individuals who private pay. For many families, that means their loved one starts paying out of their own pocket or spending down their resources. If they live for a long time, they may eventually spend down to the point where they get into our Medicaid program. And of course, Medicaid does pay for a spot in assisted living. But unlike nursing homes where virtually everyone is Medicaid, most folks in assisted living are private pay. And then in terms of what the Elder Justice Center is really focused on, and the angle in which we approach a lot of these aging issues is around the idea of maltreatment. And this is a note just as a reminder that we like to tell people that the abuse that happens in facilities can be horrific, and it needs to be addressed. And that's partly why this whole law came about. But it's also important to know that, we have way more issues of complaints in the community. So you see there, we have about 17,000 reports of maltreatment. These are reports in MDH facilities, and we have about 31,000 in the community. Yeah, Susan.
So you say that there are only about, there are 357 nursing homes and about 26,000 beds. But I mean, are you talking about nursing homes that accept patients as a discharge? Or are you talking about other, what happened to the transitional care and all that other stuff? Where does that fall?
Those are essentially included in that number. There's a few other
Okay.
There's a few other licensed facilities that are sometimes what we call swing beds, but these are skilled nursing settings. So these are sometimes transitional care where people are in and out under 90 days, but also where people live for long term.
Uh-huh.
And the trend that I was talking about is that our nursing homes have really moved away from long term where people live, and to the extent that we utilize them more and more, it is more that transition.
And a couple questions or comments in the chat that are relevant right now. Somebody asked if those maltreatment reports were for 2021. Yes, those are just for 2021. So that's not over some larger period of time. And I will also, they are not all substantiated. So those are the reports that are coming in. And then it goes through a whole lot of technical processes where some don't get looked at, and because they don't meet a threshold, or other ones do and then are substantiated. Sean, can you talk a little bit about why the shift to so many more people in assisted living, given it's so expensive? Why is that trend?
Yeah, well, so a number of factors. In fact, compared to nursing homes, assisted livings are cheaper. So in terms of the cost of care, especially our public pay programs. And so part of the shift away from nursing homes were states alleviating state budgets. Another very important trend is a realization both in the kind of older adult senior care world, but also a lot of people who live in assisted living and nursing homes are adults with disabilities, children or younger adults with disabilities in their 20s, 30s, and 40s, people with mental health issues or chemical dependency or physical disabilities. And there's been a real trend over the last several decades to recognize that those individuals want to live in the community, almost a civil rights issue. There's a really important, famous Supreme Court case called Olmstead, nothing to do with Minnesota, that came down just in the late 90s. And that case essentially says states need to actively work to fund non-institutional models. So after that case, a lot of states started moving away from funding nursing homes to funding other sorts of models. Now, as the question asked, why assisted living and things that are more expensive? We're in the phase, we spent the last several decades moving from nursing homes to assisted living. We're actually in the trend now where people realize, well, keeping adults in their own home where most of them want to stay and not moving in the first place is cheaper than assisted living. And so now a lot of the trend is to say, well, let's take some of those dollars, those public dollars that have been used for assisted living, which look more institutional, and why don't we use those for in-home care and in-home services? And that's part of the trend as well. I think what those who work in the industry and facilities will say, well, our assisted living is supposed to be more home-like. In fact, that was their argument for many decades about why they didn't want to be licensed, is they say, well, we're not really facilities. We are, home-based care. And it's just frankly not quite true. The acuity of individuals using assisted living, especially in our state, has increased because of the less care happening in a nursing home. So there are, I don't have the exact number, but somewhere 40%-ish, maybe upwards of 50% of individuals in assisted living have some sort of cognitive memory care need. And so our assisted living, it's too much to say it's the new nursing home, but really that is kind of where the trend has happened, which is why we stood up as consumer advocates and said, it's time we have a baseline general assisted living licensure system. It's not necessary, it's not sufficient to stop all things and make people safe and quality of care, but it's definitely necessary because of the acuity of those individuals. So thanks for the questions and keep them coming. I want to spend the next few slides talking about why this law was so important, frankly, and a little bit more about this old system and what the new system is and isn't. So I may have just referenced this. The old system was called housing with services. And it wasn't traditional licensure as we have now. It was actually a system in which there were two essential providers. So if you moved into one of these housing with services, you may not have known this because of the way that these two providers created their business together or contracted with each other. But legally, you would have a contract with the housing provider, essentially a landlord, and that contract's essentially a lease. And you would then have a contract with the service provider, which is essentially an in-home care provider. You could stay in your own home or apartment and call them up and have them come to you. But a lot of that industry migrated to working with landlords. So they create this business relationship and then you interface with them with these two contracts. It created flexibility for the industry to offer different models, although I think our argument a lot was consumers didn't really see that innovation a whole lot. They saw a lot of confusion, frankly. And so did the regulators. MDH, the Department of Health, when they would go out and try to do what we call the survey, which is essentially a licensing visit, they would oftentimes spend hours and hours trying to figure out if the home care provider was actually someone they had jurisdiction over. Because ultimately what would happen is we knew we had about 2,000 of these housing with services places out there, but there was no license. So all they had to do was fill out essentially it was called an application, but it was really just an information form and send it in to MDH so that they knew a place was registered. But MDH really didn't have authority over the housing with services to investigate things like the physical plant, the stairwells, the smoke detectors, the kitchen, the meals that were served. None of that stuff they had any jurisdiction over. All that they could do was say, well, the place that's giving you the services, that's doing your nursing or doing some of your personal cares, we regulate them. So that's all we're here. So it created some really weird situations where regulators would come in and there's problems with the whole place, and yet they're only supposed to focus on one little piece. So it was very fractured for regulators. It was also really, really confusing for consumers. There were no clear licensing standards, for example, for dementia care. And as I just mentioned, the acuity of individuals with cognitive needs in these facilities is growing year after year. And yet there's no clear standard And consumers are left with just whatever the place tells them. Well, this is what we do, but there's no actual, it'd be like, going to a school with saying, well, there are no standards in science in this high school. We're just going to teach you whatever we feel like. That was kind of what we had with Dementia Care across the state in these facilities. I mentioned the regulatory confusion, lots of transparencies about who the ownership are, what the fee structure should be like, what my contract is. And then there was also a lot of confusion around what are your rights as a tenant, because you're both a tenant and a recipient of services. And so that made it very confusing when the facility, either the landlord or the service provider, wanted to cut off your services or terminate your services. We'll definitely get into that here in a little bit. So next slide, Amanda, and I see a couple of questions as well.
Yeah, let's answer a couple of those, Sean. So one is about licensure for home care, and I think that this will be pretty easy for you to answer. So would you expect the licensure for in-home care services? Do you want to talk about how those are there?
Yes. Yeah, great question. In fact, so we've actually had license for home care services for a couple decades, and that's what we were using. We were using that licensure to basically regulate these housing with services. And as you can tell, it's kind of a round peg oval hole, frankly. Like there's just gaps when you try to work with it. Because home care providers, when they come to your home and you hire them, they might be doing a lot of the same day-to-day stuff that they're doing for an assisted living resident. But that home care provider isn't making sure that your carbon monoxide stuff is working, or that your stuff is shoveled or anything like that. They only care about like your physical person. Whereas when you move into a facility, you have an expectation that there are certain baseline standards around the building, the meals, the contracts, the services provided. And so we were using essentially home care to regulate all of assisted living. And it really led to those gaps. So we still have the home care law. The home care license wasn't touched. And in fact, we borrowed a lot of that for the new assisted living law, but it's much more robust. And we now have pretty close to round peg, round hole in terms of regulation.
And one more question is from Mamie, and is it true that we were essentially one of the last, if not the last states to adopt assisted living licensure? And if so, what took us so long? And the answer is yes. There's lots of answers to what took us so long. I will say that this whole model of housing with services, aging in place, consumer choice was sort of the branding or marketing of this structure, that, oh, we do it better because we let you choose more. But to keep it diplomatically, there was at best no appetite from providers to have an assisted living licensing structure. So that there was significant pushback when that ever came up. And so that was why the sort of public outrage and then political will the timing was so right for why in 2017 in 18 we could start this process. Sean, you can add anything you would like to that.
I think that's fair. I mean, a law like this doesn't come about overnight, and it doesn't just appear organically. It happens because the public is clamoring for it. It happens because there are stakeholders pushing it along. And frankly, we went through that timeline, 2017 till essentially 2021 when it came online. That's super fast, actually, for a law like this. So I think that the demand had been pent up. When I started doing legal work in this field in 2011, I asked, why don't we have licensure? That's just kind of weird. And it is in a lot of ways because the industry kind of dominated the space and made the argument for many years that housing with services was just fine. It did enough regulation and it led to enough innovation. And I think by the time the end of the decade rolled on, it was pretty clear that the gaps were significant enough. There's also a thing of timing. I think just having been in those conversations, actually sitting in the little rooms in MDH, long negotiating sessions where the industry folks wanted one thing, we were pushing for another, and the Department of Health was saying, well, can we meet somewhere in the middle? Commissioner Malcolm had a huge role to play in that. She was a huge reason why we were kind of all brought together. Also, the political dynamics of those years changed. And so there was enough appetite and enough pressure from consumers. And the fact that these consumer organizations that Amanda referenced at the beginning bonded together as well. So one day, maybe long after Amanda and I have kind of left this, you could write a little case study about, frankly, how all of the ingredients were kind of perfect to bring this about, that I don't think ultimately would have changed if any one of them had been different. So it was kind of a perfect storm for sure. It is a shame it took so long, but this is how, big laws sometimes get fixed. Good questions. Keep them coming. So, all right. So I have one more slide about kind of, okay, so why assisted living licensure? Why is it better than the old system? What gaps are you filling? And the other really big one, and frankly, this we believe this will be a model because other states licensed before we did. Yeah, they got things done earlier, but they're also kind of missing some of the innovation. And I think some of the creative consumer innovation that we have is around the discharge protections. In the old system, because you had those two different contracts, tenants were put in a very difficult position. It was very easy to discharge a tenant. And we know so much more now about this concept of transfer trauma, especially individuals with dementia care needs. A move, any move, even if it's for the good and they really need to move, creates low levels of trauma because of the disorientation, because of the lack of control, all sorts of things. So if you are telling someone, in a lot of these cases, it would happen in a couple of days or weeks because the leases were oftentimes month to month. So they would just say, I'm sorry, we're not renewing your lease, or we are, we're not going to give you services anymore. And so the person's like, well, I have to move. And the service provider, because there were two contracts, would say, no, you don't have to move. You can stay here. We're just not giving you services. Well, that's not going to work. That's why I moved here. Or the place says, well, you can still have your services. But the landlord's terminating your contract. Oh, so I have to leave. Oh, yes, I guess you kind of do. And so it was this weird catch-22 for consumers, and they had no recourse. There was no really way to appeal. Our traditional landlord-tenant laws they are not designed to really deal with folks who were moving into a place that they thought would be kind of, frankly, their forever home, or where they'd stay for quite a while. And so, and there were also very, very minimal requirements about what a provider would do upon a discharge. And this is different than other settings we have in our system. Nursing homes, much more regulated when it comes to appeals. We'll get into this in just a little bit. Group homes, where those folks I mentioned earlier, adults with disabilities, a lot of them in Minnesota live in 4-person group homes. And those have much, much more stringent protections before you can just kick them out or evict them or discharge them. And so this law brought assisted living to those standards because, again, we recognize that assisted living, the acuity of individuals living there is much higher than it used to be, and we need those protections. So those are some of the huge differences between the old system and the new system. Let's go to the next slide, Amanda.
Yep, I already beat you to it. It's there.
Okay. All right. So I'll just kind of summarize. I alluded to this already earlier when I was comparing, but so now under this new system, which again did start on August 2021, several months ago. And so all of those I mentioned earlier, there was about 2,000 some odd housing with services places. Most of them went through a process called conversion, where they became licensed as assisted living. And from now on, any place that wants to do these types of services will need to apply for a licensure. And so what it does is there's no more provider and housing provider, or service provider and housing provider. Those are one entity. They can still have business arrangements in terms of, but there needs to be one licensee. And so that makes things so much less confusing for the regulators and so much better for the consumers as well, as they will get one contract from this one licensee. And there are a lot of requirements now in law what need to be in that contract. There's a lot of standardized protections there. There are, I don't mean to confuse things too much, there's one licensee, but a provider can choose one of two licensing options. And this was a reflection to say, hey, there are kind of different levels of assisted living. There are different types. And so now in Minnesota, there's essentially two types. There's regular assisted living, or there's assisted living with dementia care. So the dementia care license would allow a provider, for example, to create a locked unit specifically for people with dementia care if they want. These are part of those dementia care standards that were lacking from the old housing with services system that are now in place. So that's one option. There's obviously clarity about who's in charge. And then in this licensing statute, a provider of assisted living needs to follow new regulations, new laws when it comes to discharging someone or terminating their contract. There's prohibitions against retaliation. When you start talking with people who have complaints about either nursing homes or assisted living, it's pretty remarkable sometimes the stories you'll hear. And then you'll have the question like, well, did you tell anybody? I said, no, I can't tell anybody. Well, why? Well, am I going to tell somebody about something that happened to me by the people who care for me intimately on a daily basis? We have a very important advocacy group we haven't mentioned yet, but we will talk and happy to answer questions. They're called the Ombudsman for Long-Term Care. Actually, part of this law was funding their office so they could do more work around the state. And what the Ombudsman will say is they talk to so many individuals who are so scared of reporting a facility because of fear of the care getting worse or being kicked out, which would happen quite a bit. And under the old system, you couldn't prove that. We didn't have those protections around discharge, so it was a lot easier to get away with retaliation, and those have been tightened up. Those dementia care standards that I mentioned are also much more clear, especially now that we know so much more that, you know, people with dementia, they need I mean, there's a lot of different things. We could do a whole day's worth of presentation on kind of basic dementia care basics, but they need stimulation. They need activity. There's all sorts of ways. They need person-centered planning, frankly. You don't need kind of a one-size-fits-all approach. And so the standards really spell that out, what a facility needs to do. And there's more as well we'll get into. I did notice the question, Amanda, and it's a good one. So if you don't necessarily need both. So if you want to do both, you need to get the dementia care license. So what a lot of facilities have done is, especially ones that are more well-resourced, they've gone ahead and got the dementia care license, which is a little bit more expensive. And that gives them the option, if they want to offer some of those more enhanced services, they can. But then they can also, like, they could have one wing of a locked unit, and then the rest of the facility could be kind of regular AL licensure. One more thing I'll say about that before I get into this slide, and this was an important negotiation and took a long time to figure out. Just because you have dementia does not mean you have to live in a dementia care licensed facility. We made sure that in the law itself, and this is a recognition again of that growing needs of people who move into assisted living have cognitive needs and dementia care needs. If even a regular assisted living facility, there has to be a baseline knowledge of dementia care and how to work with people with dementia from the entire staff, even if it's not a dementia care licensed facility. Amanda mentioned this, the Alzheimer's Association was one of the consumer groups. They taught us a lot as advocates, even though, you know, we had known about this population for a long time. So we are really, frankly, proud of how robust the dementia care standards are in both types of licenses. So I do think it's important to talk just a little bit more about these discharge protections, because again, we went from 49 states who had licensing and then us, to now we have one of the strongest, most robust laws in the country. And a lot of that is because our protections around discharge. If you think about it, if a facility can terminate you essentially anytime and just say, sorry, you got to go, and not really give a reason. There's all sorts of power imbalance, and it completely shifts the relationship between the consumer and the facility. And even consumers who say, I love it here, I just have, this issue with the care, just this happened. You are a lot less likely to bring things up if you know, or you've heard, or you've seen neighbors in your place get moved out, even when they don't want to. And so this was kind of a fundamental evening of the playing field between providers and consumers. And so now if a facility wants to discharge you from an assisted living, they need to follow rules, like I mentioned, that are similar to nursing homes or group homes. They got to do a meeting beforehand to say, hey, let's figure this out. This is a pretty, is not a novel concept in law, but it is in this space. And it's both sides really agree that we needed this, because a lot of the issues can be worked out with a meeting. Not all, but a lot can be figured out. A lot of issues boil down to your mom or dad's needs are growing and we can't meet those needs. And if you sit down and have an actual heart-to-heart conversation about it, and a creative conversation about it, 4 times out of 5, 3 times out of 5, you can fix that with some creative thinking. So the law now forces that. If the facility still wants to force a discharge, they need to give a reason. And it's not just, well, because we don't like you anymore, which is essentially, unfortunately, what amounted to in the old system. But now they basically have to prove we can't meet your needs. And if you disagree with that, if you're saying, well, I'm sorry, but Bob down the hall gets this, this, and this, you should be able to do that for me too. Then you can appeal. And now, unlike before, you can actually go to an administrative law judge and have a formal hearing. It's a legal process. It's not in a formal court, but it is in a, and it's an adjudication of the situation. And if you lose that, you can actually appeal that too. But that's for the lawyers' presentations that we do. We have another hour-long presentation on this. But this is an important playing field, leveling of the playing field. You can actually go to the ALJ and plead your case and say, make the argument I just said. They say they can't meet my needs, my dad's needs anymore because he wanders. Well, his friend Jane down the hall, she wanders, and they've put in this, this, and this. And, I think the real reason they don't like my dad is because, he says some rude things from time to time. And we can deal with that. And here's how. So anyway, you can go and then the ALJ will decide. And even if you lose that case, or you have to move, or you end up deciding to settle and want to move, the facility has to help kind of be an active participant in your move. We call this a coordinated move in the law, which again is really, really important, because that transfer trauma can be mitigated if there is a smooth transition. Even if everyone agrees, okay, we got to go. We heard so many cases of people being forced out of dementia care facilities prior to this law within a couple days. All of a sudden their stuff's gone. And usually that means they have to then go to an adult child's house, for a week or two, or some sort of transitional care unit for a week or two, or a nursing home, a higher level of care that they don't need, and then get moved again. So that one move actually turns into 2 or 3. And the literature on transfer trauma is real, and it shows real health consequences. And so we really hope that both for residents now, but really in the next 5, 10, 15 years, as the acuity in these places increase, we are really mitigating transfer trauma because of this part of the law. So that's why we spend some time on it. This, frankly, was what kept us up late at night and late into the session negotiating, because these are new requirements on providers that they've never had to do before. And we think this is part of the trade-offs if you want to do business in Minnesota in this type of way. All right, I'm just checking the clock and also looking at the chat. Amanda, do we have another question?
Yep, it has to do with, it's something we've talked about and we hear about, can an assisted living facility force medications to sort of subdue residents? So you hear about sort of the use of, frankly, some like antipsychotic meds to make somebody more passive. What are they allowed to do and what are they not allowed to do? I'm gonna let you take that.
Okay, how long do we have here?
Yeah, the shorter version, I guess.
Okay, this is a really good question, and frankly, we could even talk about this in kind of the what comes next. So, the way in which laws generally deal with this is what's known as restraints, And this is not a new issue in long-term care services. A little before my time, I was in daycare, but in the 80s, there was a large dispute around bed rails in nursing homes, and some people saying, well, I need it to prevent falls. Other people saying, well, people get caught in them and they get strangled. And so this whole idea about using some sort of restraint on someone in a facility for their own protection, or it has been around for decades. And this idea of a drug to make someone more passive is usually interpreted to be kind of, generally speaking, a chemical restraint. So under the old system, generally speaking, restraints are prohibited. You're not allowed to use restraints if you're using them for convenience or for punishment. And frankly, that law was outdated. That was written right around the time that all of those kind of bed rail debates were happening. And frankly, our understanding of restraints and how to work with someone who has some aggression issues, it's changed so rapidly, even in the last 10 years, that most laws now that deal with restraints basically flatly prohibit it. No chemical restraints, no manual restraints, no holding restraints. And the exception is oftentimes really, really, really narrow. You know, even if the family wants it or signs off on it, there has to be all sorts of things that you go through. Now that is a law that we have in our group homes and in certain chemical dependency centers. And the difference is that those are places run by Department of Human Services. So sorry for getting a little wonky here, but the Department of Human Services, not the health department, is the department that pays for all our Medicaid services, and they regulate some facilities like these group homes. So over the last 5 years, they also provide services to those adults with disabilities oftentimes, because oftentimes that population needs Medicaid to pay for a lot of their services. They have been wrestling with this idea of restraints for a long time, and they came up with a very robust law. It took years to kind of get on the books. So in a group home right now, that would be a big no-no. What you just, the example that was put out there, using drugs to kind of pacify someone. There'd be all sorts of things that you do before that. And frankly, I'd have to brush up on that law, but I don't think you could probably ever get away with that in a DHS facility. The problem is we're dealing now with MDH, we're dealing largely with private pay, and we're dealing with a law that we have just modernized in some ways. And the restraints issue, you know, when we sat down and created the law, and I'm using we here to mean dozens and dozens of stakeholders, we put a couple of issues to the side and said, well, that's really complex. We need more time to figure it out. We're going to deal with that later. The restraints issue was one of those issues we're going to deal with later. Well, later's now. We're dealing with it now. And frankly, I think the way ultimately we're going to have to deal with it is borrow a lot. The reason I went into this so much is it's timely and it's really important. We're going to have to borrow a lot of what the Department of Human Services has already done and try to then apply it to the assisted living context. If I were faced with that issue today, I would say it's likely not going to be allowed by the Department of Health, but it's a big gray area. And that's a problem. The fact that you might be able to do it in an assisted living, but you certainly couldn't do that example in a group home, that's a problem because there's actually not a lot of difference between the care needs of those individuals. So I know that was a little long, but that's a key issue, and it's something that we're going to have to wrestle with over the next couple of years. I saw another one come in, Amanda.
We're going to hit that, and the next question is going to be part of what we're going to talk about towards the end about staffing. So
perfect. I think this is my last slide for the content of the law, and then we're going to shift back to Amanda. I think for a little bit, we'll talk more about kind of what's coming. So a few more important things about, why we spent a couple of years and all that time and all that political energy changing the law, because there are other things in this law that we didn't have under the old system. We have, this is a very important one. You have the right to return to your facility. You might say, well, yeah, that's a given. But oftentimes under the old system, Another way to kind of that facilities would unfortunately get rid of problematic clients is there'd be some sort of episode, usually on growing in this population, more and more mental health issues. So there might be a mental health episode, acute episode, person would be sent to the hospital. And then the facility, the assisted living would just say, no, they're not coming back. Sorry, like we're getting rid of your bed or you can't come back. And that's not legal. And when I was an attorney at Legal Aid, we would sometimes take those cases. You would go to housing court. It's called a lockout. I'll tell you, it took forever. We might get that person back in there, and then they might not get their lease renewed the next week. So we would tell people, like, you can fight this because this is illegal, but at the end of the day, us fighting it, you might not win. And so that has changed under the new law. That is strictly prohibited. You got to let people return. And if you want to discharge them, you have to now go through that big discharge process that we put in place. And so now the shoe's on the other foot. Now it's really, if a place truly believes they cannot serve this person anymore because their mental health needs are so much greater than they can provide, well, then there's a process for that. Don't send them to the hospital and not let them back. Don't write to their son or daughter and say, come pick up your mom. Go through the legal process that's now in the statute. And so this is an important loophole that we've closed. There's also rights related to non-renewal of contract. If they don't want to serve you, if they just flat out don't want to renew your lease anymore, there's a lot more notice that they have to give around that. There's standardized, as I mentioned, we have building codes and food code issues that were not standardized. Essentially what we relied on was, and this was very unfortunate, we relied on every kind of local jurisdiction. So whether it's the local fire chief or fire marshal to take care of this situation around, regulating building codes. Well, once we centralized it to one authority at MDH, they've gone out now and started to survey facilities. And one of the first things they found repeatedly in their initial surveys, this is September 2021, is smoke detectors not working or not installed in a lot of these facilities. And this was a product of this, round peg oval hole problem of oversight that we had in these places. We've already mentioned the basic dementia care training and also those arbitrary termination rates. So there's a lot of changes that happened, as you can tell, in our new licensing statute. So what's next? Amanda and I wanted to spend a little bit of time because we talked about where we came from. We talked about the new law and kind of we could talk a little bit more about what we're seeing as it's coming on board. But, we are now, we're at the end of a pandemic, hopefully getting closer and closer, where we've learned a lot, unfortunately, about care facilities. And, we wanted to give you a little sense of kind of what we see in terms of issues in this area, both in assisted living, but also a little broader in the older care, long-term care space. So I'll turn it back to Amanda, and then I'll do a little sharing as well.
Yeah, Sean and I are just going to kind of do a little back and forth on this session. So allow us, or permit us, I should say, to kind of feed off of each other. There will be more legislative proposals both this session and in future ones. There, for many reasons, this was just assisted living alone. It's a giant change. It's a huge law. And so there are some technical fixes that are sort of agreed upon by, if there are sides, all sides. If you think about it in terms of consumers, providers, and MDH, there are things that we all know and agree upon, like, oh, we just missed this. Like in all of our meetings, we missed this. And so there will be some sort of what we call a technical bill that will likely be brought by the Minnesota Department of Health. They will have some sort of bill. We suspect, we know there are some providers have some concerns and some issues, and we will likely are seeing already legislative proposals to sort of fix or some of the laws. We would not be in agreement of all of those fixes. So we don't get to say, from a consumer perspective, great, we did this, we're done. We don't have to do this work anymore. We still have to be involved because all of these discharge protections and other protections that Sean just went through, we see as critical. They might be, they're not all, but there might be pieces that are seen as onerous, especially when you have very large assisted living facilities and then sort of the 4-bed, 5-bed, 10-bed facilities. They're very different, and we'll talk a little bit about that. The surveys, so MDH has now started doing surveys, and so and that was one of the other problems, pre-set 2017 is people weren't getting facilities were not getting their surveys done on time, or any recently, and so they should be done one every 2 years, and so they're starting to do those. You can find those. The results are now they've transitioned them and now have them on a public dashboard. So if you go to MDH and Google, MDH assisted living survey results, you'll find, and I can send you the link if you can't find it, you can contact me, but you can actually put in facilities and see their surveys. This was what Sean was referencing. So these surveys where, regulators go in and look at everything, come back and, write a report, and some things might seem minor and some things are quite concerning, but the fire alarms was something that we saw coming up last fall. That was also an opportunity for our provider partners to go out to their members and say, hey, these are the things that we're seeing consistently on surveys. Double check that you have all of these things done. Because I will say the things that they have to do are not, there are a lot of steps and there's a lot of rules for facilities. And so how do we make sure that facilities have the tools and the education and what they need to operate the facility and also keep residents safe? So we are seeing building code problems and then staffing concerns. And I can't remember if this is on a future slide, but I'm going to address it now. I think it is. If you're reading the paper, you are hearing of staffing concerns. And this is not to us, those of us who work in aging issues, a new thing. This is just now we're talking about it more. So long-term care has been understaffed and under-resourced for a long time. And they know this and they have been saying it. So this is it gets very technical, but reimbursement rates for those who are on Medicaid have not been keeping up. Assisted living is expensive. And frontline staff, think of like LPNs, not even LPNs, CNAs, nursing assistants, are doing the bulk of the work and not making a living wage. So they cannot keep getting people into the field, and keeping people into the field is very difficult. And even with some of, and so COVID brought all of that to light, right? All of the other things that we already knew were a problem in this field, COVID exacerbated it. And so even with some of the, COVID relief dollars or paycheck protection programs where people could pay staff or even give increases for their staff. So let's say they could now get them from $15 an hour or $14 an hour to $20 or $25, then that staff person who is working full-time would lose their public benefits because they probably weren't getting robust benefits in the way that we need them to live from their employer. They were on public benefits and eligible for some support that way. Well, if they're now making $25 an hour temporarily, they would not qualify for their public benefits and lose money there. So it's complicated, but ultimately it is under-resourced from both reimbursement and from the state level. So staffing is still a concern. You can make more money going to a lot of other places and doing that work. We also do not value it. So as a society, and so there's a lot of work that we, and I mean, not me, but like the collective we are doing around this with the Leadership Council on Aging that we are a part of, which is a council of, frankly, all the aging organizations in Minnesota. I serve on the board of that, along with providers and other aging organizations, and we're really concerned. And so there's a lot of work being done at the U, but you hear about even just the temporary frontline worker relief needed at the Capitol this session. And that's just like the tip of the iceberg. So that was maybe longer than I meant to take on that, but it's, yes, it's, we're concerned and will continue to be. And not super optimistic that we're going to have a real productive legislative session, even though in any of the ways that we need a productive legislative session. Sean, I think this was you.
Yeah, it is. And I'm happy. I'm the one. So I'm at the Capitol. I'm at the virtual Capitol every day, and that Amanda is right. Unfortunately, even though we have almost a $10 billion state surplus, a lot of us are skeptical that there will be a big, robust agreement on funding a lot of these challenges. I do think there is still some optimism that there will be some funding coming out of the legislature this session, even to address more acute staffing crisis needs. Wouldn't be the permanent fixes that we would need. Amanda mentioned it. A lot of workers in this space are not paid a living wage, and some of them are in private pay, but that's also our public pay programs, Medicaid, essentially, that funds essentially everyone in nursing homes and funds a growing percentage of people in assisted living and everyone in a group home. The wage that pays trickles down to the worker and does not meet a living wage. And so we could change that by funding those programs with more dollars. And there will be some funding at the end of the day. But even the bigger proposals that are coming out are not going to be enough to make, permanent impact. So that's one of the key ways, that's one of the key issues over the next 5, 10, 15 years in this space are how do we support the workforce with more permanent wage increases and actual career opportunities. Back to other issues that, that deal specifically with the law that we passed and then all of the ripple effects. Amanda mentioned it earlier, and I believe, when the Affordable Care Act was passed, there was a line that that's now is pilloried at the time. Somebody, and I forget who it was, but somebody said, well, people will figure out what's in the law once we pass it. And it sounds kind of ridiculous, but I will tell you there's certainly a grain of truth to that. If you kind of think about, listen, when we're writing this law, some of it is like our best guess. And a lot of it is also, consumers wanted us to go here. The provider organization said, no, we should only go here. So we met here. Well, we don't know exactly what the full effects of going here, is going to be when it comes to those discharge protections, or when it comes to some of the dementia care standards, or when it comes to some of the building codes. And so we are going to need at least a couple of years for the department to, fully survey every single facility. In the past system, they had to survey every 3 years. Now they'll survey every 2 years. So we'll have a little closer eye on kind of what's happening, get feedback from providers and say, this is kind of a waste of your time. Yeah. Get feedback from consumers and say, this hasn't changed. We passed the law. We thought we'd do this. And so I suspect, as Amanda said, over the next couple of years, we will learn more about the small provider population, these facilities that are under 10, because they've existed for a couple of decades under our housing with services law, but they were fairly neglected, to be honest, from a regulatory perspective, and they were kind of forgotten about. So now that they are really brought much more into the system, we will know more about their needs. And there are already several new organizations of small providers at the Capitol saying this new law, it's too onerous on us, essentially. And so we will be working through some of those challenges and trying to listen, because the consumer organizations, we never wanted to over-regulate anything. We want to right size. Again, we want to make sure that it's a round peg and a round hole. And so we don't want to be too restrictive. There's also a lot of specialized providers in these settings. Some providers, I mentioned earlier, most people in assisted living, the aggregate number are private pay, even if many of them eventually spend down their money and their savings and get on a public program, Medicaid. But some places only serve people on Medicaid. And so those places have unique challenges because, again, Medicaid only pays a certain rate, and it may not cover everything that we contemplated under in the law. This is a good time to answer that question.
Yeah, so do you want to answer it? I can too. It doesn't, yeah.
Yeah, so has essentially the regulation, I'm paraphrasing, but has the regulation, limited the number of assisted living beds? No, not that we can tell. There was about 2,000 or some odd providers who were registered as housing with services, and there's about 2,000 assisted living. There's some churn, but the bed capacity also isn't as big a problem in this area, because one thing I didn't mention about nursing homes, I should have mentioned this. The other reason we moved away, well, one of the reasons that made us move away from nursing homes, or in response to the move away from nursing homes, there's actually a moratorium in most states and in Minnesota about the building of nursing homes. So you can't just go as a provider and say, I'm going to open up a nursing home. You have to get a legal exception, which is a pretty onerous process. You can in Minnesota just say, you know what? I want to open an assisted living, and there's no, you have to go through the licensure process, but there's no moratorium or anything. So there's not a big concern that there will be less kind of physical access. The question is, will there be affordable access? The question I think that these smaller providers are asking is, will the cost of regulation make it too expensive to run, especially if all of my residents are on Medicaid? And I think that's an open question. And we are interested at the Elder Justice Center to make sure that BIPOC communities, underserved communities, we know in Minnesota we have racial disparities in all sorts of areas, healthcare, education, and unfortunately, long-term care and senior care is no exception to that. We don't have great outcomes in our long-term care system. We actually have a lot less data than we have in those other places I mentioned. So we do need to do a lot more to make sure that the system is working for people of color in our state, and that is something that the law certainly was necessary, but not in any way sufficient to do that. So we need to build on that, and we hope that we can be a part of, the question. There was a question: what is Minnesota Elder Justice Center doing? Part of our work at the Capitol, we work in coalitions. And so working with Consumer Coalition, working with providers to say we need more staff as well, and then working with other coalitions around these questions of access for the BIPOC community is really important and a part of what we do.
The other thing that I just wanted to touch on the is there a lack of or a loss of beds with assisted living? A couple of some providers did choose to say, we're not going to offer any services anymore. We're not going to be in assisted living. Now we're just going to be independent living, which means here's your apartment, senior living, there's no services. But right now, as a consumer, if you're going out and trying to find a place for yourself or your loved one in assisted living, it's hard. And so there might be a perceived, a real kind of lack of space. And it has more to do with the staffing crisis than it does with the licensure. So facilities are saying, we don't have enough staff to operate floors 3, 4, and 5. So we can only have people on 1 and 2. So there might be empty beds or empty rooms, but there aren't people to do the work. That is something that our staff are hearing from people who call us.
Thanks, Amanda. That's accurate. It's also true if you want home care. I don't want to move anywhere. I just want to stay in my own home and bring someone in. It's really difficult to find the staffing for that. I'm going to go through these quickly. The questions have been great, and we want to leave time for more and discussion. But some other issues that we see on the horizon is that this is a little bigger now than just the assisted living. But our system for a long time, going back to that demographic slide I showed you, most people in Minnesota who need care receive it from somebody who's unpaid, a family member, a spouse, and that's kind of the not talked about system behind the system. And I think we need to continue to find really creative ways to help caregivers, because someone, by the time they move into a facility like assisted living, family is burnt out. There's a lot of stress. A lot of what Minnesota Elder Justice does, unfortunately, is respond to situations where there has been abuse or neglect. And in some ways, those can be root causes because of that stress or lack of resources. That we just talked about how the pandemic has laid bare the caregiver crisis that we've already had in this field. We've relied on, frankly, communities of color to do the labor in this space and have paid them low wages and benefits for a long time with difficult jobs and a lack of public investment. We also have a private insurance market that basically has failed for all intents and purposes, and that's long-term care insurance. It was an idea that we thought would really take off in the 80s and 90s, and it just never got the legs to actually be a viable option, to be honest with you. And so it's a really tiny part. And so, people have had to save on their own, or, a lot of times if they live long enough and spend down their assets, then use this Medicaid system that I've been referring to so often. And that was never designed or prepared to meet, the large population that we're going to have in the next 10, 15 years. And so we're really going to have to wrestle with how we've designed our Medicaid system and how we've funded it.
And I can just give you a little kind of example, kind of a case example of how this staffing crisis is butting up against safety. We had a client this fall who was had finally secured and with our help and decided to get an order for protection, which is difficult to get. So met levels of threshold of safety violence to get that, got that against her adult child, who was also her caregiver in her home, and was going to have this person out, had the protection order, was working with the county, was working with our staff, was working with lots of people, and couldn't get in-home staff to come in. The county was kind of washing their hands with it and saying like, well, they can't get services. So the client was going to drop the order for protection because the only choice for this person for care was abusive adult child. So we worked with that, pushed back on the county, worked with this to try and resolve the situation differently. But like, those are the real, like, those are not good options. And so the staffing crisis is really important to us, and because it's really important to clients and people who need it. So, and the way to get more staffing is better wages and drawing people into the field. So, Sean, I'll let you.
I think you're up for the last one.
Oh, I am. Yes. Okay. Yes. Well, we're going to wind down here in the next few minutes. I'm just going to take a couple minutes on this slide and then we can open it up for more broader discussion and conversation. Just the Minnesota Elder Justice Center. This is one of the issues that we have been working on and that we have felt was really strongly that it was in alignment with our mission and our clients. But, if you think back to the demographics slide that we talked about earlier, where we have about 1 million, 65 and over adults, and older is not a set term in our world. So you could be, frankly, 45 and older, depending on your cultural or lived experience, or you could be 80 and you could have and be not have any vulnerabilities and capacity issues, and you are just fine on your own, or you could need all sorts of assistance. So we really look at vulnerability and disability. So about 60% of our clients are dealing with some sort of a disability or vulnerability in their life, and we are looking at balancing that protection and autonomy. People get to choose what they want for themselves, even if somebody doesn't have what somebody might consider full capacity. Like, you still have the ability to have a say in your life. And so we're really looking at how to help people reduce abuse, neglect, and financial exploitation despite where they live. And we've talked about that. Most older Minnesotans don't live in assisted living facilities or nursing homes. So this has been really important work for us, and we will continue on it. But we also, about 2/3 of our clients, and this bears out nationally, their perpetrators of maltreatment are actually their loved one or family member, friend. It's not a paid caregiver. So we work a lot in that financial exploitation world, with orders for protection and safety, but also on our adult protection system. And this is a whole nother presentation, but it's a county-based system of they look at all the maltreatment, those 37,000 other reports that came in 2021. Every county is mandated to have an adult protection system where they look at those cases. And they follow the Vulnerable Adult Act, which I know Mamie Siegel on here has had a hand in helping revise with other members of our board, I believe back in the 90s when it was last revised. We're working on that now with the Department of Human Services on updating that Vulnerable Adult Act again, and also looking at some of the disparities that we see because we have a county-based adult protection system. So we have all 80 some counties responding to these cases differently. And there's been some evaluation done. And we see by and large, the takeaways are Minnesota rejects more cases for investigation by far than others nationally. So our counties are only accepting, I think around 30% of those cases that come in. They're only accepting 30% of those to support and investigate. Nationally, that's 60%. So we're falling behind on those cases. And these are people that are living in communities. And we also know that the cases that are kind of getting kicked out of the system are disproportionately people of color, people with chemical dependency issues, and people with severe mental health issues. Hard cases. So the Elder Justice Center has spent a considerable amount of time this past 2 years, and this is another other proposals that we're working on at the legislature this session, and we will be next session as well, is working with the Department of Human Services to address some of the disparities and make some improvements to the Vulnerable Adult Protection or the Vulnerable Adult Act, and also fund county-based adult protection. 30 seconds I'll take, and then we can turn to questions. But in Minnesota, the adult protection systems are funded by the counties themselves. So Hennepin County funds its own adult protection system. Carleton County funds its own adult protection system. It's in many ways an unfunded mandate. There is no direct federal funding for it. Counties can get CDBG funds, their community development block grant funds for it, but you're fighting against, frankly, child protection and other social services. And really there's no direct mechanism from the state for it. So that leads to disparities. So if you are self-funding, kind of the county self-funding it, it's based on how much money your county has, how much your county board might be allocating towards. And so the support that you receive or the number of adult protection staff a county might have is very different from county to county. So I will stop there, but these are some of there are just other broader policy systems change issues that we think are critical that we will also be addressing in the future, now and into the future. We're going to give you this PowerPoint so you can send it around, and these are links. Our website has, I think, most of these resources on it. So I won't read this, but we do have handouts on assisted living licensure on our website. We also do free webinars every Thursday, typically every Thursday at noon, and you can sign up on our website to do those. And you can also see kind of the greatest hits, or the most, I'll call it for lack of a better phrase. Sean and I have 2 other presentations that are on our website that are on assisted living. So you can kind of go deep on other elder justice issues by watching presentations that we've done in the past, or feel free to sign up for our future webinars. And I'll leave this up here for just a minute. Our office number, you can reach me through that. Our helpline or advocacy services, we always want to make sure everybody knows that we have free, confidential helpline services. We're not a 24-hour emergency line, but we have highly trained advocates or attorneys. We have 4 staff that work in our victim services program that do just fantastic work. And we encourage you to spread the word. If anybody just needs to call and bounce things off of them, you don't have to give us your name. You don't have to tell us who you are. So we're happy to kind of walk you through whatever situation you might be experiencing. And I'm going to stop share And we have, I think, 8 minutes, and we're happy to take any other questions that you might have. I think we got to them all in the chat. But yeah, happy to take other questions.
So question about how the word is getting out around Minnesota. It sounds like you're doing a lot of education. Is it part of required continuing education? What requirements are on different entities to get this knowledge?
Yeah, that's interesting. So the as part of the new different ways, and probably not coordinated enough, honestly. So the assisted living licensure law, every facility has to have a director, an ALD, and then they are required to have so many certain continuing ed credits that would relate to this as well. If the facility is a member of one of the provider organizations, Leading Age or Care Providers are the two largest ones. And honestly, if I were a consumer, before I was putting anybody working with my family member to enter one, I would actually want to make sure that facility was a member of Care Providers or Leading Age, because they're going to get a ton of information and training through those. So I know, for example, Care Providers is doing a, like an assisted living summit where they really, I mean, it's their job to make sure that the providers that are members of theirs are doing this. The Department of Health has done some. I've been critical of them to their face, so I feel like I can say it here. I feel like they've really worked well to try and get the law, and ready, but they have not necessarily taken the lead as maybe they should in communicating effectively and clearly to providers or consumers. So the Ombudsman's office has done some, and then we try and do some for consumers as well. But there has not been, the education push has been so focused on making sure providers got their license. First of all, did they get everything in on time so that they could be licensed? And then what do they do now? The legislation or the education has really been around that. The consumer side has probably been less than it should be. Somebody probably has to seek it out. Sean, would you add any?
Yeah, just real quick, as part of, if you think about it as a consumer, you're not going to come to one of these presentations. Usually, you're going to find out because you're shopping around. And if you are planning ahead, then sure, you got enough time to, or if something happened and all of a sudden you're in a transitional care unit and then you can't come back home, you're kind of forced into the situation. So we do need to create better resources for the public. The key tool that is still being developed is known as an assisted living report card. And that was originally part of those discussions in 2017 or 2018. But frankly enough, I learned a lot. Like doing a report card is an effective one is really, really hard. And in fact, we have report cards for nursing homes and they haven't worked very well. There will be 5-star nursing homes that are horrible. Or they're just not super effective. And so unfortunately, we will eventually in Minnesota have a report card system run by DHS, not MDH, so the Department of Human Services, which I know we've thrown a little bit of that soup at you, but that's one of the challenges, frankly. So Joni, it's really something we need to do better on as a state.
Sean, do you want to talk about one of my favorite things to talk about and push for, staffing ratios?
Short answer, no. We lost on that.
No, you don't want to talk about it, or no? Yeah, we don't have them.
No, I do want to talk about it. The short answer is no. We do not have a strict ratio as other states do. And the short answer is because we lost in negotiations on from a consumer side. I mean, we do think I mean, the literature, it's not like it's the earth is round type of proof, but there's pretty good correlation with staffing ratios and more staff available, that incidents are reduced, critical incidents are reduced, and the quality of care is better. If you can imagine it, this was before COVID even, the industry was never going to go for a strict ratio. And there are states that have ratios in assisted living, but unfortunately when the national kind of federal law around nursing homes was developed, which is federally regulated, the consumer advocates lost on ratios too. I can say lost because I know many of them, or the folks who worked on that and talked with them, and they think it's something that, you know, they wish they could have gotten. So it would have been weird to be, not weird. We had an uphill battle. We had to prove, like, why do you need ratios in assisted living when you don't even have to have them in nursing homes? So the short answer is no. We did fight and win for very strict guidelines on a facility. They basically have to prove, here's your ratio. The law says you have to have a ratio and then prove why that's your ratio and that it's safe and effective. And so we do hope that that plan that they have to do, which has to be pretty robust, is essentially the proxy for the ratio. And we fought hard to make sure that that plan is not watered down. It's one of those things that we're going to be monitoring over the next couple of years to make sure it actually works. That's a great question. And a pretty good way to end it.
I'll say there's 2 minutes if anybody has a final one. But we
Not
really
a question, and I
yeah.
know Colleen and Joni will thank you all, but I just want to say I am so grateful and proud of the work the Elder Justice Center does, and Amanda and Sean are stars, and hearing kind of the passion and the commitment just makes me grateful that you're both here. And I'll put in a plug, you know, that Minnesota Elder Justice Center is a nonprofit. It you know, gets funding from various foundations and also from individuals. So anybody who wants to learn more about that opportunity, you can go to the Elder Justice website, but they certainly put money to good use in terms of protecting Minnesotans. So personal thank you, and then I'll let Joni and Colleen thank on behalf of the league.
Yeah, we're a small and mighty staff. There's 9 of us, and we're across the state, and we serve statewide. So we're not some like we're 9 staff, and plus Sean part-time as a contractor, and $1 million budget, and we make do with what we have, and we have a fantastic board. So Mamie's been with us for the past 8 years since I started. It was just me and the board, a little closet room at William Mitchell. So I've been grateful to do this work with great people and excited that we've been able to do this. And Sean has been like, everybody should have a technical expert. You just work with really good people who are great in all ways that you aren't, and then they can help elevate the work. So feel free to contact any of us if you have any questions. We appreciate the opportunity to be here to talk with you.
Well, thank you very
This has
much.
been an excellent presentation. I don't think an hour and a half has gone so quickly in my life recently. Thank you so much. So much information. And I just want people to know there will be an article in the Leaguer. I know Barbara's been taking notes for Kathy. And so the links will be embedded in the article. We can also put the recording on our website. And so please, people who are here tonight, know that you can forward it to friends and neighbors and other people you know are concerned. But also Amanda and Sean, we will give the links to you. And I'm thinking our senior center.
Yeah, absolutely. And we do before COVID, we were in long-term care centers quite frequently, but we're happy we go and present anywhere. So I don't know if probably couldn't do this in the facility. It's probably not the right, but this presentation, but we certainly talk about.
They can also, they're members of the senior center.
But they can watch the tape. Yep, absolutely.
Thank you.
Absolutely.
Thank you.
PowerPoint, and they can see
Yes.
you going to share that. That would be also good information, nice summary to have as well. But thank you so much. And you know, you kept mentioning, Sean, a round peg in an oval hole. They're everywhere. I mean, it's staffing, it's customers, it's families of the customers. I mean, there's all these round pegs in an oval hole, and it's so hard to make everybody kind of coordinate. So I understand your efforts, and sometimes just being sort of disappointed that it doesn't go quite as quickly as you would like. But it's great that we have such good people like you and many others. And Mamie, thank you for serving on the board. It's been a great presentation, and I agree, it's wonderful. One thing I thought of, I had parents in Pennsylvania, and you know, when you go to another state, you've kind of got to learn how that state works. And there are probably others on this call that might be having that same sort of thing. And you know, where would you? This may be too big a question. Where would you go to another?
You can certainly start by calling our office, and we get those calls. And so we can help work with you, we can't necessarily, we don't know anything about necessarily about Pennsylvania, but we know if there's some states have an organization like ours, most don't. We're kind of unique. So, but we can send you to an ombudsman in that other state, which is also the other, frankly, best place to go. Find whoever is the ombudsman for long-term care in whichever state you're looking in. But you can also call our office and we will find you somebody in North Carolina or California.
Well, thank you so much for your time and all your great information, sharing it with us and letting us share it with others. That's great.
Well, thanks for having us, and
Yeah.
thanks for your energy around all sorts of issues.
Yeah.
It's great to talk with you all.
Thank you so much.
Good night, everybody.
Thank
Okay,
you.
have a great night.
Thank you. You too.